Good evening and welcome to the first UT Southwestern Science Cafe for 2022. We welcome both our regulars and new guests to this ongoing series. My name is Jenny King and I'm part of the public affairs team here at UT Southwestern. This is our third year to host Science Cafe and we are so proud to produce this series. On behalf of my colleagues, Joya Lang and Charlandra Thompson, as well as our guest speaker tonight, Dr. Parag Joshi, thank you for joining us. Science Cafes are online conversations where our speakers take you on deep dives into science topics. At UT Southwestern, we are an academic medical center, and this means we bring together research, medical and health education, and patient care into one institution. And the research and education informs care advancements quickly, which is truly a benefit to our patients and our community. We also have fun at Science Cafes while we learn. Our format is casual and interactive, and we encourage you to ask questions and engage with us during them. This evening, we are discussing cardiology, your path to heart health with Dr. Joshi. We have a few technical points to cover before we begin, and those that we are recording tonight's program as well as live streaming it on our UT Southwestern Twitter page. Please mute your microphones to help everyone's audio clarity. We encourage you to use the chat feature to list questions for Dr. Joshi. We are monitoring questions in the chat box, and Q&A will start at the conclusion of his presentation, with Joya facilitating this part of the program. And finally, while we cannot answer personal medical questions, we would love to hear from you with your general heart health questions. And with that, I am pleased to introduce our guest speaker. Dr. Parag Joshi, professor in the Department of Internal Medicine's Division of Cardiology here at UT Southwestern Medical Center in Dallas. He specializes in heart disease and preventive cardiology, including abnormal cholesterol, family history of heart disease, and early atherosclerosis attacks and strokes. He also performs and researches non-invasive cardiovascular imaging. Dr. Joshi is a team member of the UT Southwestern Dallas Heart Study and was on the Today Show talking about this important study and its impact on our collective understanding and control of cholesterol. Check out his bio for the show link and watch it after Science Cafe tonight. Dr. Joshi, thank you for joining us this evening. We appreciate this latest opportunity to work with you. Welcome to Science Cafe. The virtual podium is yours.
Great. Thank you so much, Jennifer and Joya and all of you out there in the audience. It's fantastic to see this interest in preventive cardiology, and I look forward to spending the next hour with you. I'll cover a few sort of what I think are some of the important points in prevention and heart health, and then I really look forward to getting to your questions and having some discussion about about all of this in the Q&A. So with that, let's go ahead and get started. As is common for our talks, I'd like to just, in full disclosure, I do receive some grant support from several sources, and I do participate in some clinical trials and do some editorial work on one of the leading journals in cardiovascular medicine, which is actually housed here at UT Southwestern, the journal Circulation. So with that, we're going to cover a few topics, but a lot of what we'll talk about today is codified for us in these guidelines from 2019. And in cardiology, we're really fortunate. It's a really fast-paced, quick-moving field in terms of research. And in order to keep all of it together and really prioritize what's the most important findings, the things we should be doing for our patients, the things we should not do, the things that we might do based on, the best research. Guidelines really help us keep all of that straight as in such a dynamic field. And so the guidelines for prevention, this was the first time that guidelines had been written specifically for primary prevention, were chaired by one of my mentors from training, Roger Blumenthal, and one of our very own, Dr. Amit Kara, here at UT Southwestern, who's the director of our preventive cardiology program, was a co-author. So I'll be alluding to these guidelines quite a bit in our talk. Just as a way of an outline, we'll spend a little bit, I'll take you back to biology class so we can talk about atherosclerosis so that we can really get an understanding of that process that we're trying to prevent. And then we'll walk you through the ABCs of prevention. I'll highlight the Dallas Heart Study, which is research that's happened at UT Southwestern for the last 2 decades. And for some of the points that we'll talk about, I'll bring in some of our studies from Dallas Heart Study and how we've really moved forward, in our view at least, contributed to how we prevent heart disease and strokes today. And then I'd like to end with a top 10 sort of take-home message for all of you to consider, and then really looking forward to getting to the Q&A. So let's start with plaque or atherosclerosis, which is depicted here. So if we think of our arteries as pipes, this is a pipe or an artery that's cut open in half. And what it's depicting on the left is really a normal looking artery. And you can see there's complexity to the artery. As I tell my patients, it's not just a pipe. The walls actually have a lot of important functions. And the inner lining of the walls of those arteries is called the endothelium. And on the left, the sort of first starting point of developing plaque in the arteries is that wall, that inner lining, losing its ability to keep things separated, and what we call endothelial dysfunction. And smoking, high blood pressure, diabetes, these are all risk factors for endothelial dysfunction. Once we have that, once someone has endothelial dysfunction, it becomes easier for things that are not supposed to get into the wall to get in there. So we have cholesterol particles floating around in our bloodstream. And when there's endothelial dysfunction, there's the ability of those cholesterol particles to deposit inside the wall of the artery. So that's where it's not supposed to be. And that triggers this process of atherosclerosis. Our body reacts to that. Our defense system, responds and says, well, this cholesterol is not supposed to be in this area, and it triggers an inflammatory response to that. And that can become quite detrimental to our own arteries. Over time, it can progress to form full plaques. And what we really don't want to happen is that those plaques become unstable. So I almost think of it like a blister forming inside the wall of the artery. And if it were to rupture there on the right-hand side of this slide, a plaque rupture, well, that bloodstream, that blood flow that's going in there, that's not supposed to come in contact with the wall, now loses that wall loses its integrity. And just like when you cut yourself, shaving or cutting the vegetables, a blood clot forms. The problem, though, is in an artery, a blood clot forming inside the artery can shut off blood flow altogether. And really the consequence of that in the heart, when it's the heart arteries, is a heart attack. And when it's in the brain, it's a stroke. When you cut off the oxygen or blood flow, that's when you get damage. And really that damage is what we're really trying to prevent in cardiology. And so while we do hope to prevent the formation of plaques, that's something we call primordial prevention. What we really find most important is to prevent heart attacks and strokes, the damage that is caused by this plaque formation. And so we'll go into a little bit of how we prevent those things. So with that in mind, Dr. Blumenthal, who was the chair of the prevention guidelines, is a big Jackson 5 fan, and he's always used the ABCs as his way of teaching preventive cardiology to his patients. And he incorporated that into these guidelines for prevention. And so we'll walk through these ABCs over the next 20 or 30 minutes or so before we get to the Q&A. So the first, before we get to that though, I do want to set up the Dallas Heart Study and explain that, because we're going to come back to some of the research we've done there and how it applies to some of these ABCs. So the Dallas Heart Study was started about 20 plus years ago here at UT Southwestern. And it's a single center study where 6,000 people were enrolled, and a bunch of detailed data were collected at that baseline visit 20 plus years ago. And then they followed them. For the last 20 years, we followed folks who were in the initial DHS or Dallas Heart Study. And you can see in that map of the country where those people have migrated to from originally being in Dallas. So they're all over the country now. And we continue to follow them to collect information on, have they had heart attacks? Have they had strokes? And we can go back to those baseline factors and say, well, what predicted who was going to have a heart attack, or what was more likely to be associated with future risk of heart attacks and strokes. And there's been subsequent phases. So the Dallas Heart Study, or what we call DHS, the phase 1 was that initial 6,000 participants. DHS2, or the second visit, was completed about 10 to 15 years ago. And we brought some people back from DHS1. We brought some new folks into the study, and we got more data, and have learned a lot from that phase. And currently, the third phase is ongoing of DHS, and it's more specifically focused on healthy aging and healthy aging of the brain in particular. So we're kind of abbreviating that one, or calling that more of a sub-study called the Dallas Heart and Mind Study, as we're really interested in how do people age in a healthy way. So we'll come back to that in a second. Just to keep all of you guys engaged, we're going to have some poll questions. And this is the first poll. And this is really important, I think, a really important concept. But do you know your numbers? So do you know your cholesterol, your blood pressure, both, neither? And hopefully that poll is coming up for you there, and you can start submitting your answers. I'm going to submit mine. And maybe after we have enough answers, we can share those results with the audience if that's possible. Great. So there's a good spread, and I'm glad to see that the majority of you, 80+%, know both your numbers, and many of you know at least one of those numbers. So that's fantastic, and I think really important for monitoring your health. Cholesterol, blood pressure, these are oftentimes, many times, silently elevated or in an abnormal range, and there's no sign or symptom that we have that can tell us that these are abnormal, but they play a huge role in the risk of heart disease in the future. So let's start with A in the ABCs. A is assessing risk. The first A is how do we assess risk? And this is a critical concept because we have a lot of tools in our armamentarium here, and we have the ability to treat lifestyle very aggressively, or we may need to use medications, cholesterol medications, blood pressure medications, but we want to target those interventions to the people who are at the highest risk, especially the ones that have more potential side effects. Prevention is tricky because what we do is not designed to necessarily make you feel better, especially when we talk about medications in people who already feel well. What we do is we're trying to prevent future events. And so sometimes that can be a challenge. And getting someone to take a medication for the rest of their life to prevent something that we don't know for sure is going to happen requires a little more knowledge about the risk, if they don't do something about it. And so assessing the risk is very important. And here is a kind of a guideline here of how we approach this in a somewhat simple way, but don't be overwhelmed by this. This is basically showing a group of people with some who are destined to have a heart attack in the future. And what we really try to do is get an idea of their risk of that event in the future. And those that are in the higher risk group here, we treat more aggressively. In this example, potentially with a medication like a statin. Those who are in the lower risk group, we focus more on optimizing their lifestyle. That's important across the board. Everyone, we want to focus on this. But when do we start to bring in these other interventions is when we start to find higher risk. Then there's a big gray zone of this in-between risk where some of these folks are at higher risk and some of them are not. And we have other ways to kind of get to that. But how do we assess this risk in cardiology? Specifically, this is talking about a 10-year risk of a heart attack or stroke. So how do we assess that? And we do that based on a lot of studies in the past, including studies like the DHS or the Dallas Heart Study, where we know some very common risk factors that can inform broadly what someone's risk might be for a heart attack or stroke over the next 10 years. And really, those are composed of age. Age is the biggest driver of this. So unfortunately, not a reversible thing, but the older we get, the higher the risk is for a subsequent or future heart attack or stroke. Sex is important. So up until a certain point, men are at higher risk. And then eventually after menopause, women tend to catch up and maybe even exceed men's risk in the older age ranges. Different races are affected differently in terms of how these risk factors contribute to their risk for heart disease. Cholesterol values are very important, blood pressure values, diabetes, and of course, smoking. So these are all very important factors, but there are limitations to these calculators. One that we've focused on is what about these have been derived and validated, meaning they've been studied and sort of proven to work in certain populations, particularly white populations, Black populations. But what about other groups? We're a diverse country, and we have a lot of groups of interest here who suffer from heart disease. How do we get better evidence for them? So that's one of the papers we published from the Dallas Heart Study. This is about a year old now, where we looked at this specifically. We used the Dallas Heart Study and another study to look at how these risk estimators perform in Hispanic individuals across the US. And what we found, this is a bit busy for you, but what I really want to highlight is the difference between the red bars and the blue bars. So we looked at different forms of that calculator, and we looked at Hispanic individuals and compared to white and compared to Black individuals, and used the calculators to sort of see who was at higher risk or who was at risk, and actually how many of them actually had heart attacks and strokes. And what we saw across the board is in the red bars, this is the predicted risk. And in the blue bars, we see the actual number of events. And you can see that we overestimate the risk in the red compared to blue bars. While we do a good job of identifying who's at higher risk and who's at lower risk, we're not very accurate with that risk to say, here's your actual risk. We generally overestimate it across the board. So that was one important finding from the Dallas Heart Study. So what do you do when you're not quite sure? You get a kind of ballpark, low risk, high risk, especially in this intermediate group. Well, how accurate is this? And we're making important decisions on this. But we have some other factors we can look at, in particular, something called a risk enhancer. And I'll just go through a few of these that were published in the recent guidelines. One is, these are things that are not in that risk calculator, but that we know when present do suggest maybe higher risk. So people who have a family history of early heart disease, meaning first degree relatives who had blockages, heart attacks at an early age or strokes at an early age. People who have high cholesterol values, even though their risk is not calculated very high because maybe they're young and otherwise don't have many risk factors. The metabolic syndrome, these are folks who have increased waist circumference, higher triglycerides, higher blood sugar, higher blood pressure, tends to go together with that increased waist circumference, probably reflecting something we call visceral fat, which I'm happy to discuss more if there's questions. Chronic kidney disease is a risk factor for heart disease. Chronic inflammatory conditions, rheumatoid arthritis, psoriasis, HIV, those are risk factors for early heart disease. There are some female-specific risk factors: premature menopause before the age of 40, and pregnancy conditions, associated conditions like preeclampsia during pregnancy. And certain ethnicities are at higher risk. Unfortunately, myself, being South Asian ancestry, is a little higher risk. So some of this is a selfish endeavor for me. There are some biomarkers or lipid tests or cholesterol tests or blood tests that can be informative. An inflammatory marker called C-reactive protein, lipoprotein A or LP(a) tends to run in families with heart disease, and high triglycerides is another one. So while we don't, the guidelines tell us that when these are present, they're a risk factor. We don't have a lot of guidance on when these should be measured, because it's really an individualized decision that you should have with your clinician, your doctor or your clinician, when talking about your risk for heart disease. Okay, so let's go to another hot topic, another A, letter A, aspirin. We'll pull up our next poll question, and this is an important one. So I have never had a heart attack, a stroke, or blockages in my arteries. Should I be taking a baby aspirin to prevent heart disease? And let's go ahead and give everyone a little time to submit their answers, and then we'll share it with the group. The choices here are definitely should be, definitely not, most likely not, but occasionally yes, or I don't know. Maybe we can share those results. There we go. Good. So a nice spread here. So we had about 1 in 10 who think definitely, about a quarter of you think definitely not, nearly half say most likely not, but occasionally yes, and then 15% or so that say they're not sure. And that's great. So you guys may have seen here in the last few months, and just a clip from one headline here, that most adults shouldn't take a daily aspirin to prevent a heart attack. A crucial piece here that's missing from a lot of the headlines is that if you've ever had a stroke, heart attack, blockages in your arteries, stent placed, bypass surgery, blockages in the peripheral arteries to the legs, this does not apply to you. Those folks definitely benefit from aspirin. This is for people who've never had a heart problem or a stroke or a blockage in an artery. And in that setting, about 3 or 4 years ago, 3 really large, well-done, randomized controlled trials of aspirin in folks who have not had prior events showed that there is some small benefit in lowering the risk of heart attack and strokes with a low-dose aspirin. There's also a small risk of increasing bleeds. And overall, it's hard to pick out who's going to get the risk of a bleed and who's going to get the benefit. And so as a result, the broad recommendation had changed from, yeah, maybe you should take a baby aspirin to maybe you shouldn't unless there's some special circumstances. So we decided to look into this a little more a couple of years ago from the Dallas Heart Study again. And we have a test there that I'm going to talk to you a little bit more later about called a calcium score. And we found a group that does benefit from aspirin, from a baby aspirin, if they have a high amount of coronary artery calcium, which reflects a lot of plaque in their arteries, and a low risk for bleeding. So again, a way to individualize that decision to a patient, and something to discuss with your doctors if you fall into this category. Good. So that's the aspirin data. I'm sure there may be questions still about that. How about B, blood pressure? So blood pressure, hypertension, really the consequences, and a lot of what we focus on is how do we protect our major vital organs. So hypertension over time can damage the brain, leading to strokes or dementia, vascular dementia. Obviously can damage the heart or increase the risk for heart attacks, heart failure, atrial fibrillation. But also the kidneys take a beating from high blood pressure, so it can lead to kidney disease. The peripheral arteries take a beating, so that can lead to peripheral artery disease. And the eyes, even retinopathy, affecting the eyes from high blood pressure that's not treated. So high blood pressure is a very important risk factor. And oftentimes people with high blood pressure, nearly everyone with high blood pressure, until it gets very, very high, has no idea they have it unless they actually check it. And so that's why it's super important you guys know your numbers. So third poll question, we're flying through these. True or false? My blood pressure should be less than 130/80. What do we think? Give everyone a few seconds here to answer that, and then we can pull up once we have a good representative sample of answers. Great. So everyone, or 90% say true. And I think that in general, that's probably very accurate. But we'll go into a little more detail there, why that might not be exactly perfect. So here's from the blood pressure guidelines that came out in 2017. And there was a big sort of a hubbub about this because it increased the number of people who were going to be considered hypertensive because the thresholds changed. It used to be 140/90. And then it kind of moved to this 120/80, maybe 130/80. And I'll walk you through this. So normal blood pressure in those guidelines was defined as less than 120/80. So if your blood pressure is usually less than 120 on top, less than 80 on the bottom, not all the time, but on average, then that's great. That's perfect. And we just want to focus on maintaining that and focus on optimal lifestyle habits. Elevated blood pressure in those guidelines was defined as the top number, systolic blood pressure, being between 120 to 129, and the bottom number being less than 80. And for those folks, a class 1 recommendation, or our highest, strongest recommendation, to focus on non-pharmacological therapy, non-medical therapy, meaning diet, exercise, weight loss, lowering your salt intake or sodium intake. These are great ways to lower blood pressure, and very effective ways when our patients accomplish it. And then stage 1 hypertension, that's defined as a blood pressure of 130 to 139 on top, or 80 to 89 on bottom. And for that group, we go back to that key principle of risk assessment. If you have a low risk, then we still focus on those lifestyle modifications. But if you have a high risk and you're in this range, it's lifestyle modifications plus a medication, lifestyle modifications plus a blood pressure lowering medication. And then stage 2 hypertension is greater than 140/90, where for all of those folks, regardless of their risk assessment, they should be on a medication when it's routinely above those values on average. All right, so this is another area where we looked into because more people were being told they need to be on blood pressure medication. So we looked at the Dallas Heart Study amongst some other studies, and we found there's 2 blood tests that can be drawn that are measures or markers of stress or strain of the heart. And those can really be informative amongst these groups. And we found, without going into too much detail on these graphs, we found that about 30% or 1 in 3 folks who felt fine, but were in that elevated blood pressure or low risk stage 1 hypertension group had an abnormality in one of these blood tests. And if you were in the higher risk groups, about 50% or 45% had an abnormality in one of these blood tests. And what we really found in that study was that if those blood tests were abnormal, the risk for an event over the next 10 years, heart attack, stroke, congestive heart failure, atrial fibrillation, these kinds of things, was much higher than if that biomarker was totally normal. So another way to individualize to our patients to help them make decisions about preventive therapies. Moving along to the letter C, just checking my time. Good. I think we're doing okay. Cholesterol. So that's a big one in preventive cardiology. And I'm sure there will be questions about this. So I'm going to highlight just one aspect of it. And it's really this test called a calcium score. And so going back to our model from our early on in the presentation, how does plaque form? One thing I didn't highlight was this area here, this calcified plaque. This area is calcification is what's in our bone. Calcium is what makes up our bones. And for whatever reason, the body has developed this process when plaques have developed over a long time as they mature. There's some calcification that happens, which ends up leading to hardening of those areas, which you may have heard in the past. And that calcium is something we take advantage of in a test called a calcium score. And so I'm going to show you an example of a calcium score here. You guys can see that pointer. So this is a CAT scan of the chest. And what I'll highlight here is what's white up here. This is bone. This is a patient's breastbone, and you can see some ribs coming off. And we're going slice by slice down their body, and we're focusing on the heart and the arteries that go around the heart here in the middle. And the lungs are here to the side, and we're getting to the stomach down at the end. And what you'll see is some bright white streaks that show up, and those are in the arteries around the heart. And so what that reflects in this patient is coronary artery calcium, calcification in those arteries. And the only reason, essentially, for most people that you would have that is if there's plaque there, if the plaque process has been happening, and usually if it's been happening for some time. And what's really nice about this score that we've validated in studies like the Dallas Heart Study and multiple others is that the more calcification there is, the more plaque you have in general. And the more plaque you have in your arteries, the higher the risk for heart attacks and strokes in the future. And so this is a nice test to take a look under the hood, as we like to say. This builds up silently, as plaque does. And it gives us a look to see, hey, regardless of risk factors, do you have plaque buildup in your arteries? And if you do, then that puts you in a different risk category, and we need to be more aggressive. Importantly, what's really nice about this test and where we use it the most is here. What we all hope to have is no coronary calcium at all and no plaque in our arteries. And here's a nice example where you don't see any of those white streaks in the arteries around the heart. And this can be a really helpful test if I think you need to be on a cholesterol medication and you're really hesitant to do that. This can be a nice tiebreaker for us. And if you don't have any evidence of plaque, at least at that stage of your life, then maybe we feel a little more comfortable holding off on a cholesterol medication. And potentially we repeat it in a few years to make sure none is developed in the interim. And so that's how I often use this in my practice. This is not a screening test, meaning we don't do this in everyone. And the main reason for that is there are some considerations here. There's radiation associated with CAT scans. There's the potential of incidental findings or unnecessary testing that can come after a test like this. So it has to be done in a thoughtful way and discussed with your physician for sure. The next one here in the ABCs is cigarettes, and I'm going to lump. I think everyone here, I hope, knows that you shouldn't smoke, and if you're smoking, quit smoking, and there are resources to help you with that if you need them. And diabetes, it could occupy several of these sessions, so I'm not going to focus on that other than to say there are some really great therapies in the last few years that have come out that help with diabetes, but also lower the risk of heart disease. And you should ask your physician about those if you have diabetes. But I do want to focus on diet and exercise and go through that with an example. So before we do that, one last poll question. How much should I be exercising each week? And we have at least 100 minutes of moderate intensity, 150 minutes of moderate intensity, 45 minutes of vigorous intensity, or 75 minutes of vigorous intensity, or either B or D. All right, let's see if we have a good sample there and we can share that with the group. All right, very good. So we had good. More than half of you said 150 minutes of moderate intensity activity, and a third of you got either 150 minutes or 75 minutes of vigorous intensity physical activity. And we'll go over what that is. And that's the right answer is that it can be either of those. And we'll go into more detail about that. But I want to leave you in this presentation before we get to our take-home points with this interesting paper from a few years ago. It's one of my favorite studies. I did not do this study. It's one that came out in the Lancet about 4 or 5 years ago. I don't know how many of you have heard about the Chimene indigenous population. It's a group of about 16,000 people that live in Bolivia, and they live a pre-industrial lifestyle along a tributary of the Amazon River. And just to give you an idea, they spend only about 10% of their daytime is inactive. The lifestyle is a hunting, gathering, fishing, farming kind of lifestyle. Men spend an average of 6 to 7 hours of their day being, quite physically active. Women about 4 to 6 hours being quite physically active. For comparison, we spend about an average of 50% of our time in sedentary activities in Western societies, such as sitting there for this talk. But they do have a high degree of infectious diseases, which actually should lead to a lot of inflammation, which is a risk factor for heart disease. But this study from the Lancet did coronary calcium scores in about 700 members of this population aged about 40 to 95 years old. And the results were pretty fascinating. What they found is that this group has the lowest burden of coronary artery calcium or plaque in their arteries in the world. So we've looked at the coronary calcium score across the world, including here in the Dallas Heart Study. And here you can see women and men, women on the left, men on the right. And you can see as people age, there's more coronary calcium, more plaque in the arteries. But the very bottom line here is a blue line that you almost can't see distinguished from the lower axis there is the Chimene population, where they just have a really not very much coronary artery calcium or plaque at all. And the reason I bring this up is to highlight some of the differences in their diet and their lifestyle. There's probably plenty of reasons why this is the case, that they don't have much plaque at all in their arteries. But some of it, I think it has to do with this. The diet of the Chimene is composed largely of complex carbohydrates that are high in fiber, with rice, plantains, nuts, and fruits. Protein is only about 14% of their diet, largely from animal meat that's caught, in the wilds. Their diet's very low in fat, with only 14% of their calories being fat calories. That's about as low as the traditional Okinawan population that is known for having tremendous longevity. And it's in the range of the prevention studies of Dean Ornish. And it's very low in saturated fat, and there's virtually no trans fats. In contrast, in the U.S., we have a lot more carbs. a lot more fat, 34% fat, 49% carbohydrates, and about 16% protein. And really one of the key differences here is the type of carbs, right? We have a lot of processed carbs that are not similar to the complex carbs that you see in the Chimene diet. And the reason I bring this up is to really highlight the importance of lifestyle and some of the trends that we've seen here in this epidemic of obesity, is certainly concerning in a broad sense. And so let me end there with some take-home points. The top 10 take-home messages. So the most important way to prevent atherosclerotic vascular disease, heart failure, AFib is to promote a healthy lifestyle throughout life. A team-based approach to that care is important. And here at UT Southwestern, we have a nutritionist, we have an exercise physiologist that we're incorporating into our group, and nurse practitioners and a nurse who's fantastic with preventive measures. And we try to make sure that everyone gets exposed and access to those folks in our preventive cardiology program. The social determinants of health, as we've learned a lot over the last 2 years, there are factors that are outside of the clear biological factors that we've done a lot of research in. There are social determinants of health that are super important in all of this. Adults age 40 to 75 years old should undergo 10-year risk estimates, risk assessment, and then have a discussion with their clinician about starting medications, blood pressure medicines, statins, aspirin, and should assess for other risk-enhancing factors like we reviewed in certain cases, and including potentially a coronary artery calcium score. All adults should eat a healthy diet, emphasizing the intake of vegetables, fruits, nuts, grains, lean vegetable or animal protein, fish, and minimize the intake of trans fats, red meat, processed red meats, refined carbohydrates, and sweetened beverages. For those who are overweight or have obesity, counseling and caloric restriction are recommended to achieve and maintain weight loss. Adults should engage in 150 minutes a week of moderate intensity activity. So that would be 30 minutes at a time, 5 days a week, or 75 minutes of vigorous activity. And vigorous activity would be that which kind of gets a really good, works up a good sweat, and where you can't really complete a sentence as you're working through and getting to a high level of activity. For those with diabetes, there are some important lifestyle modifications are an absolute must. And then there are some important new medications that can help lower their risk. Again, if you're smoking or anyone who's using tobacco should absolutely quit. Aspirin, as we talked about, probably should be used a little more infrequently unless you've had one of these events, heart attack, stroke, blockages. Then it's a medicine that all of those patients should be on. And then statin therapy is our best treatment if we're going to use medications to lower the risk of heart attack and stroke, and should be used in the appropriate groups at risk. And then non-pharmacological interventions are recommended for everyone with elevated blood pressure, lifestyle modifications, low salt diet, exercise, weight loss. And if you need to use medications for blood pressure, you should try to get your average pressure down below that 130/80. And so I'll leave you with a picture of my two sons that are 1 and 3 years old, and this quote that's been attributed to Dostoevsky, that the second half of a man's life is made up of nothing but the habits he's acquired during the first half. And so here we can see my boys out playing at the pumpkin patch and voraciously devouring the apple there. So thank you for your time. I look forward to some question and answer session. And if we can't get to your questions, please email to heart@utsouthwestern.edu, and we'll try to get back to it. Thanks.
Thank you, Dr. Joshi. I've already learned so much, and I know we're about to learn even more during this next segment. So we will now get into the Q&A portion of this session. While we can't get to all questions, I'd like to jump right in. First, we will start with some questions submitted ahead of time, and then we'll also address questions in the chat. So if you have any questions that come up, feel free to just type those in the chat. First question that was submitted, not by me, but it does apply to me. Can too much coffee cause heart issues? I've made coffee part of my morning routine, and I think heartburn and palpitations is a result. Sad face.
Yeah, that's unfortunate. I suffer from the same problem. If I don't watch things, then the coffee can give me a little heartburn. So, it is something that I think has been associated with heartburn, amongst many other things. Things that can help with heartburn, weight loss, avoiding alcohol, avoiding chocolate, unfortunately. There are ways to kind of mitigate that risk, but certainly I have heard many patients develop a little bit of heartburn once they start drinking coffee.
That is unfortunate news, but thank you for answering that for me.
Not everyone though, so hopefully most people don't suffer from that with it.
Our next question comes from Rudy. Is there a way to reverse calcium buildup?
Good question. So calcium in the arteries is sort of your body's natural reaction, and it's probably protective. We talked a little bit about that plaque rupturing being the real bad actor there that can lead to heart attacks, a blood clot forming. So that calcified portion is believed to be less likely to be able to do that. So that calcium, we're thinking, is probably more protective. The real bad actor, if you will, is the non-calcified plaque, the plaque that's developing, that can be a little more fresh and can actually be a little more likely to rupture or get really inflamed and be more unstable. The calcified plaque gives us an idea of what's happening there, but is not necessarily the problem. Generally, we don't see calcium in plaques change or sorry, I shouldn't say change, but we don't see it regress or go away. Once the body starts calcifying an area, it tends to keep calcifying. But again, the real problem is the plaque that is reflected by it.
Thank you. Our next question comes from Emmy. When do you decide someone needs the CAC screening test?
It's a really good question, and it's a really individualized test, and we're real careful not to call it a screening test, because screening means we do it to a large group of people because we're just looking for the problem. It's really got to be in the context of what else is going on with a patient and what decisions we're going to make. Anytime I get a test, I try to talk to my patients about what do we expect the results to be. Could be this, could be that. And how is it going to actually help us make decisions? What are we going to do as a result of that? And so you really need to have that discussion. If you're not going to make any changes based on that test, then you shouldn't get that test for the most part. So, everyone's individual circumstance is different. So I couldn't give you a broad sort of answer of who should get it and who shouldn't, but it's really worth discussing more with your doctors.
Thank you. Our next question, Joanna asked this, and a few people actually asked it ahead of time. Do you have any comments on the Mediterranean diet?
Yeah, absolutely. It's the Mediterranean pattern diet. For those of you who may not be familiar, is a diet that's rich in sort of nuts and legumes. Uses a lot of olive oil to cook with, as opposed to olive oil is a unsaturated fat, whereas saturated fats are solid at room temperature, like butter or coconut oil, which I know a lot of people tend to use because they think there's health benefits. But coconut oil is actually solid at room temperature and turns into cholesterol in our bodies. So the Mediterranean diet actually uses olive oil in the cooking, prioritizes fish or lean meats, and a ton of fruits and vegetables and healthy forms of carbohydrates. And so it's a fantastic diet in theory. And in studies that have looked at it, diet research is very hard because most people know what they're getting. But in the studies that have looked at this, in the best quality studies that can be done in this space, there does seem to be an association with a lower risk of heart disease in people who follow a Mediterranean pattern diet. So it is one of the diets that we recommend in preventive cardiology for most of our patients.
Thank you. And what about the vegan diet? That was another question that was submitted ahead of time.
That's a great question. A lot of people have gone that direction, and it really depends on what you're consuming in that diet. If you're prioritizing protein from vegetable sources, if you're prioritizing your fruits and vegetables and not getting too much into sort of the potentially unhealthy, especially this comes up with vegetarian diets where there may be a lot of cheese or breads or things like that. It can be a very healthy diet. A plant-based diet tends to improve a lot of the risk factors that we see. One of the issues with any diet is, can you sustain it? And if you can, then it's a great diet.
Our next question comes from Jean. You mentioned sugar and fat. Are diet drinks like Diet Coke okay in moderation?
So yeah, everything is probably okay in moderation. It depends on how much moderation means. There's no right or wrong answer there. If you are going to drink sodas, then potentially diet sodas at least don't have as much of the traditional sugars that we worry about. So I often advise using the diet version if you're going to drink sodas. There are some other concerns about sodas, even if they're diet drinks, but if you're going to drink them, then probably use the diet route.
Our next question is from Jan. What causes aneurysms?
Good question. There's a lot that goes into that, and there's different places that aneurysms form, but an aneurysm is essentially the artery wall being a little weakened and then dilating as a result. So your arteries are what that blood pressure is pumping through every beat. So when we say your blood pressure is 120/80, it's seeing that 120 pressure every heartbeat. And so if it's not strong, or if there's for some reason some weakness to it, or the pressure is really high in there, then it can start to dilate. And as it dilates, it can start to, the risk for a tear or a rupture through that increases. There's a ton of different reasons why people get it, but there's also risk factors that make it more likely. So there are some genetic predispositions to aneurysms, and we do see some families that have aneurysmal diseases that kind of run through multiple members. But high blood pressure is a big one. Smoking is another big one. We see it very commonly in 50, 60-year-old men who acquire an aneurysm. They don't have any genetic risk necessarily, or an identifiable genetic problem, but they may have smoked, or they may have had high blood pressure. Generally, when they did both, or when they had both, that's a big risk factor for developing aneurysms, particularly in the abdominal aorta.
Thank you. Laura says, I do not see anything regarding the effects of sleep apnea on the heart gone untreated. Any thoughts or comment on this?
Yeah, sleep apnea is a really important diagnosis to make, and we probably underdiagnose sleep apnea. Sleep apnea is a problem where the airway tends to close off at night when people sleep, and when your brain tries to get to the deepest levels of sleep, it has to wake back up, not all the way, but wake up a little bit so that it can open the airway and get more oxygen in. And so you never get good quality deep sleep. And your oxygen levels sort of fluctuate a lot at night. And one of the hallmarks, this isn't everyone that snores, but snoring is a big hallmark because it's a sign of an obstruction of airflow down. So snoring and a lot of fatigue, generally very common as we put on more weight, that can happen. The effects on the heart of that over time can be some more stress on, particularly on the right side of the heart. The right side of our heart is what pumps blood to the lungs. And so if there's a problem with oxygen levels or the lungs, then the right side can start to suffer from that. The other risk factors that go along with sleep apnea, high blood pressure, is a big one. And so, I told a patient today in clinic this same thing, but more than anything, I feel like when people have sleep apnea and they treat it, they feel 100%, but they feel like a new person. And it's one of those things that more than anything we do, they say, wow, that completely changed my life. So it's an important thing to look for and diagnose if people have it, because it can make a big difference in how they feel. It does involve sometimes having to wear a machine at night. That takes some getting used to if you have it.
Thank you. Our next question, they say, we know to avoid processed meat, we don't eat red meat, but we can't figure out if high quality turkey breast from the deli is considered processed meat to be avoided.
So the big issue there, it's a great question. The big issue there is deli meats tend to have preservatives and tend to have a high sodium load. And so sodium is really tied to blood pressure. So again, things in moderation are fine and not overdoing how much you take in of this. But if you're someone with high blood pressure, then that can be a source of some sodium, and that could play a role in why you might not be able to achieve the blood pressure control you want, or leading to more medications being added on.
Ben asks, can calcium from food affect the calcium score?
Yeah, great question. Something we get often. No, it's not related to the calcium levels in the body or calcium that you intake from food. It's, we all have calcium floating around in our bloodstream because we need to fix bone and build bone and break bone down and all kinds of, it's an active process all the time. And similarly, these places where it's depositing in plaque is really more a response to the plaque that's there. It's not the calcium that's bad that's in the arteries necessarily. It's that there's plaque there and your body's reacting to that. So it doesn't really come from what you eat. There's very rare problems with kidneys that can lead to calcium development in different places in the arteries. But for 99.99% of the time, when we see calcium in an artery, it's because of the plaque. The plaque is the bad problem.
Thank you for answering that. I actually was wondering myself, so I'm glad that someone asked. Sarah asked, she's a busy working mom. She does a lot around the house, on her feet a lot. How much working out would be recommended per week in addition to that?
That's a great question. So, I often talk to my patients about how much time are you being sedentary? And Sarah sounds like she's not going to be sedentary very much. She's up on her feet, all the time, not sitting hopefully not sitting at a computer for too long, but if she has to for work, getting up, taking walking breaks. But that doesn't get the heart rate up and keep it up at for a chunk of time, 15, 20, 30 minutes. So when we talk about not being sedentary, it's being up on your feet, being active. When we talk about exercise, we're talking about getting that heart rate up and stressing it a little bit, training it a little bit. And that's a different type of activity that's beneficial for your heart. So there's two pieces to it. There's not being sedentary. And Sarah, sounds like Sarah's nailed that. She's not sedentary, but then also having that dedicated time where you get your heart rate up and keep it up for a sustained period.
Thank you for clarifying that. Walt asks, is resting heart rate an indicator of heart health?
It's a tough one. That's a great question. It's an indicator of a lot of things. So it'd be hard to pin it down to just that. It can reflect sort of what the body's demands are, what the body needs. And so hard to say for sure. In general, broadly speaking, on a population level, the lower the heart rate at rest, the better other physical conditioning is of the heart. But for a given individual, that can vary quite a bit.
Thank you. Nope, that's not Bart. Janice asks, can you explain the aspirin issue just a bit more? How do I determine if I should stop taking it?
Sure. So I don't think I can advise you specifically, Janice, but in terms of whether someone should be on an aspirin is a discussion with their physician. If someone's had a history of heart disease, blockages, strokes, anything like that, then they often are on an aspirin the rest of their life appropriately. It's very beneficial, and it's dangerous to stop it in that situation. If someone has never had those issues, then it becomes more of a discussion with their whoever's prescribing it or whoever's advised them to take it, or whoever they're seeing as their physician. So there's only a small group amongst those who have not had heart attacks, blockages, that where we can find a indication for it. But it's hard to really comment on any individual's case in this forum.
A question that was submitted ahead of time. Are there any known effects of COVID on heart health? We know it's relatively new. However, for people who have had COVID, is there any evidence of it affecting heart health?
Great. Yeah, great question. So many people unfortunately have had COVID. And so, and a big question is, does it affect the heart? What parts of the body does it affect? What are the long-term effects of COVID? We're still learning a lot about it. There are people who with COVID, just like with other viruses can have it specifically attack the heart and cause some inflammation in the heart. And so that we see, and because it's so prevalent, since we're seeing so much COVID, we may see more of that in general than the usual respiratory virus season. But overall, as long as people recover from their COVID, they mostly tend to have recovery of their heart function, save for a very small percentage of people who can get really sick from the heart standpoint. The main effects, at least in this early, or at least in these 2 years, is really in the respiratory side of things and the lung damage. And then there are there's a lot of ongoing studies on the long-term effects of COVID. So once someone's gotten through the acute infection of COVID, survived it, but may feel not quite right for quite some time. And there are studies, autopsy studies of people who had COVID months before, where people are finding evidence of the virus still in other parts of the body, like the heart muscle. So there's still a lot to be learned about COVID. One thing's for sure, the pandemic and spending more time indoors and sitting more, and that's also affected heart health quite a bit. And blood pressure on average seems to have gone up overall, for broadly speaking, whether people had COVID or not. So it's going to be really important for all of us to prioritize staying active, heart health, and staying in good shape. And we know we've learned quite a bit about who does poorly with COVID, and so we all want to be in as good shape as possible, and vaccinated and boosted to survive if we do encounter that virus.
Thank you. I'm going to do just a couple more questions. Maria asks, can severe anxiety cause any heart damage, or is there any evidence of this?
Yeah, so stress and anxiety certainly are probably tied into heart health. There's an interesting condition called broken heart syndrome, or Takotsubo's cardiomyopathy, and it's generally tied to, it's been seen quite a bit, and well described, very stressful situations. So really extremely stressful situations can lead to the heart muscle becoming weak all of a sudden, and it's probably tied to a surge of adrenaline type of hormones in the body all of a sudden, to a very dramatic event. And it's interesting because the heart can become very weak and very affected by it, and then it goes right back to normal after a few days. But it can look like a massive heart attack, really. And so in that degree that we do see it, but overall, I think it's more of a chronic issue when people have stress and anxiety. May lead to higher blood pressure, probably leads to more unhealthy habits, stress eating, not exercising as much, not sleeping well. And then that obviously affects kind of the whole picture.
That's fascinating. Last question, and then I'm going to also put the heart email address in the chat after we finish this. So that way, if anyone has any questions that we didn't get to address, you can send it to that email address. But the last one is from Stephen. How is potassium related to heart health?
It's a good question. There's not a really direct, I guess I'm assuming, Stephen, that you're asking about the potassium levels in the blood. And generally that's something that the heart, the electrical system of the heart generally relies on pretty stable levels of the electrolytes like potassium, calcium, magnesium in the body. And sometimes when people have certain heart conditions, the medications that they're on can really change those potassium levels, which can in turn affect the electrical system of the heart, if you will. And so that's probably the only direct line I can draw to it. There is, in terms of treatment and replacement of sodium, potassium might be a healthier way to get some of your intake. So fruits and vegetables that have high potassium content are probably better for blood pressure. But that's probably the most direct line I can draw is really more on that electrical side of things. There was one question in the chat, if I can jump in, that's, does statin cause muscle aches? And if yes, how to minimize it? This is a super common question, and statins being our best medication to lower your risk of heart disease, specifically if you have a higher risk. I think it's really important that that you talk to your doctor about if you have muscle aches when on statins. About 10% or so of people on the first statin we try them on can have some muscle aches, and it can range from very mild aches and pains to sometimes very severe aches. The nice thing about it is when you stop the statin, it goes away. So you just have to know to look for it. Often patients get put on a statin, which is a cholesterol medication, and they don't know to look for the muscle aches. And so while they may be suffering from aches and pains, it could have been their statin. They just didn't know to link the two. But with everyone that I start on a statin, I let them know about that. Many of that 10%, so let's say we started with 100, we had 10 of them that got muscle pains on the first statin. I can switch them to a different class of statins, and about 7 of them will do fine on that one. So ultimately, we get down to about 3% or so where we still have persistent troubles on the statins, and we can get kind of creative where we do alternate day dosing or once a week dosing, and there's alternatives to statins in people who really need those.
Thank you so much, Dr. Joshi. This was fantastic. It was fascinating to learn about heart disease prevention and some of the details that you shared. It was really enlightening, and I'm just joining in appreciating your top 10 take for heart health. And I appreciate you mentioning the UT Southwestern Dallas Heart Study, because it is so important to really the world's health and their cholesterol. Thank you to Joya for helping run tonight's event. Also, I'd like to thank my many colleagues at UT Southwestern and our communications, marketing, and public affairs department who support this program, several of whom are on tonight. But a special thanks to our fabulous heart marketing team led by Alvaro Fernandez Palamo and Anna McEwen. Thank you. To all of our guests, join us again in 2 weeks on Thursday, February 24th for the next Science Cafe on the future of stroke prevention, care, and recovery. Check out the chat for the registration link, and we'll also be emailing you the details and links soon. After that, we will have a program on colon cancer on March 10th and on liver transplantation on March 24th. Beyond Science Cafe, we're hosting a community education event with our colleagues at UT Arlington and UT Dallas called COVID Year 3, Vaccines, Variants, and Your Questions Answered. This will be at noon on February 22nd, and the registration link is all set. And before we adjourn, we must implore you and your friends and family to get a COVID vaccine and your booster shot. Vaccines protect you from severe illness and death from COVID-19 and its variants. And we're so grateful Omicron is fading, but we are not out of the woods yet. Thanks so much for doing your part to contribute to our collective public health. And for wish you good health, good spirits, and a good rest of your evening. We are adjourned. Thank you.
Thanks, everyone.